Reuben Warren is professor and director of the Tuskegee National Center for Bioethics. He has adjunct appointments, professor of public health, medicine, and ethics, interdenominational theological center, clinical professor, Department of Community Health and Preventive Medicine, Morehouse School of Medicine, professor, Department of Behavioral Sciences and Health Education, Emory's Rollins School of Public Health, and professor, Schools of Dentistry and Graduate Studies, NCMEDRCoP. Dr. Warren was Associate Director for Minority Health, Centers for Disease Control and Prevention. He directed Infrastructure Development, National Center on Minority Health and Health Disparities, NIH. Formerly, he was the Dean of the McCary Medical College School of Dentistry. He has numerous accolades and is someone who I deeply admire. Anytime he talks, I always learn something, and I know that you will too. But I just always honor you, and I appreciate you for all that you do, have done, and continue to do. So, the doctor that needs no introduction, Dr. Reuben Warren. We're going to have them pull up the slides. They have it nicely laid out.
Yeah, this Dropbox stuff, so that it's dropped in the box.
Yeah.
And again, I have to say over and over again that I'm a dentist. It's always unusual to have a dentist in these kinds of forms because people don't think about oral health as a part of general health. So, and what the one part for me is that, particularly for children, the prevalent chronic disease for children of color, particularly black and brown children, don't carry. Those present preventable diseases, and that's preventable. Something can prevent completely, and it unfortunately impacts upon children of color. So what I learned over my years of learning is that most of the challenges we have are not scientific challenges. The scientific acumen, research enterprise in this country, in most parts of the world, is phenomenal. Do all kinds of stuff. So as I continue to learn and study about the science of research, the coordination, what I found is not that we don't know what to do, we choose not to do it.
Amen.
And that taken it to a different place in my educational journey. We do our place to make it move. I'm on this social media journal. I just got my Twitter installed.
There you go.
Transparent. I didn't even know what to do. It wasn't even installed. Look at your Twitter app. I didn't have it. So now I'm on Twitter. I'm not sure that's all good.
Yeah.
And it's the time that I have with you in my 15 minutes of this. I want to talk about what I think is the greatest challenge in this country, if not the world, and it's a moral imperative. It's a moral imperative. compare. And morals, people use morals and ethics synonymously, and they're not the same. And so it's important to distinguish, for me, between the two. How I treat someone else is a moral issue. The right or wrong of treating someone else is a moral issue. And how I want you to treat me is an ethical issue. And sometimes they're very different. Treat me a certain way, but I don't want to treat you a certain way. So that's a dilemma. And these times in this country particularly, we are challenged with a moral dilemma. And every day, turn on the idiot box, and we're confronted with issues that we know the answer, and we reframe the question to fit the answer. Moral dilemma. Health professions education is a moral dilemma, and I'm so proud and pleased to be with you here because transforming medical education is a moral dilemma. It ain't working. 85% of health has nothing to do with health care. Nothing. And so no matter how good it is, or how correct we want it to be, it really doesn't address the concerns. Much of the challenge is outside of the health delivery system. When I was a dental student, I'm a dentist, and I was frustrated because the things that I was doing, and Harriet trains, educates dentists really, really well. The things I was doing didn't have anything to do with the folks I was treating. They would come back with a different problem, not a dental problem, a different problem that I couldn't address. The very foundation of the history of this institution was created out of a moral dilemma. So it's in the mission, the vision, the DNA of this institution to do what Dr. Reuben Warren and Dr. Paul and Dr. others are doing. It was historically addressing the current problems. And I'm just sharing a context of my few comments there. See that first, I didn't push that button. I'm going to go back. There it is. You see the Sankofa bird looking back to move forward. And so you're here and this place called Harry's House Grounds. And look back as we move forward. Back as we move forward. There's an African proverb, I am because we are, therefore we are because I am. That gets confused in the context of these United States. Because some folks think that they're bigger than where they are. You know, I'm at Tuskegee, and that's much bigger than who I am. And so I always let people know that what I do, in large part, is because I'm at Tuskegee. Because I tried it before, it didn't work. I didn't get any better. I just changed the environment in which I tried. So it's important to separate who I am as a individual and what I is scholar in the context of where I am. And so as I'm thinking about this social media, you know, hashtags and all that, don't confuse Tuskegee University and my hashtag with Reuben Warren and my hashtag. All right, they're two different things. So in the context of where we are, and then we're not literally on the campus of the Harry Medical College, just know that's the context. That's the domain, that's the ethos. If you ever get to Tuskegee, when you step on that ground, you will know you're on our ground. The ancestors reach out and talk to you. If you're quiet and still enough to listen, they tell you what to do. So if you're at Tuskegee, you're not confused about what to do. You have to figure out what you can do, because it's not new. And the relationship between Tuskegee and Harry is historical. And the more we look back, the more we see that things have not changed. When I was here as an administrator, we had challenges with access to patients. Particularly Mahara medical students, couldn't get patients, patient material. You were all upset. We became 5 patients. And y'all bear with me, I almost feel it in my time, right? So they had to come to Tuskegee to see patients, teaching material. And that was in the 30s and 40s. And then when I came back as an administrator, same thing. So the government built they renovated a hospital in Murfreesboro. So the students could go there and rotate. And back in the 30s and 40s, Manhattan students had to come to Tuskegee to the VA hospital, which was a black hospital, because they couldn't access the hospital, the VA hospital here in Niceville. Now, I'm not here. Has that changed? If it hasn't, it ought. That's an ethical dilemma. And Tuskegee gave the federal government the land to build a hospital if they would assure that the leadership would be African American physicians and administrators. That's the ethical dilemma that continues. I am because we are, therefore we are because I am. I'd like to talk to you in the context of justice. Justice is fairness, which has a central place in the value of community. This is community practice. So what is just within the context of community practice? I suspect that leadership said that something ain't right with medical education because the outcome is not what we think it ought to be. So we need to transform medical education. That takes a lot of courage to transform medical education. Because what I interpret that transformation is in the context of social justice, which is the foundation for public health. That's where I spend most of my time. And hopefully for the practice of population health care. Because that's what we're talking about, identifying populations in need of the best that we can offer. And historically, Mahari has always served the underserved, and the common language now is vulnerable. But I would suggest to you that vulnerable is not enough. It's not the way in which we're operating. These populations are a subset of the vulnerable. A subset of the vulnerable. So if you do the general vulnerable populations, you won't miss them. So the most vulnerable, I would argue, is the susceptible. And to peel it down to the very nature of who is in greatest need. And those are susceptible populations. That's the population, the practice of population health care. John Rawls, one of the giants in philosophy, in his book on the theory of justice, says that each person possesses an invulnerability founded on justice that even the welfare of society as a whole cannot override. So no matter who you are, who you be, nobody has the right to violate, to deny you justice. Therefore, in a just society, the rights are secured by justice and are not subject to political bargaining or to the calculus of social interests. So nothing should change your right to be who you be. Nothing. And I suggest that the population that we're dealing with have been robbed of justice. And what I hope we're trying to do is make it better, if not make it right. And some would argue that would raise the question, is justice a human construct or a divine construct? Who decides what justice is? I don't know about you, but I'm real clear about where justice resides. I don't know about you. And in the context of health care and research, I start with the moral authority at Tuskegee University. Because that's where the quote unquote, the Tuskegee syphilis study, so-called, was launched. But that's the real name. The U.S. Public Health Service syphilis study at Tuskegee, 1932, 1970. Now you heard about it. If you haven't, act like you had. And then go to the library. But don't even believe what you read in the library. Come to Tuskegee. We can clear it up. And I leave you with these thoughts about that so-called study. Withholding therapy, the longest non-therapeutic study in the history of this country, if not the world. Non-therapeutic, that means we ain't giving you nothing. And more importantly, we were clear about who we were targeting. We traveled the world and we found ourselves in little old Tuskegee, Macon County, Alabama. And I'm using very appropriate terms because we're in a very appropriate, comfortable place, professional place, but deception, in my context, that means you were lying. Simply lying. Exploitation. And think about this susceptible population that we're dealing with, and those things fit. They fit. And so I want you to think about, as we talk about ethics, think about the place, the people, and the principle. And if you get to the principle, it's generalizable around the world. The place, the people, and the principle. And guess what? I guess they exposed it in 1972, and in 1997, the government apologized. I'm sorry. I was there. And it sounded good. But the more things change, you know the other part there, the more things they simply apologized. And I say they because I was in the conversation. I was on the Tuskegee Legacy Committee, but I didn't apologize. The irony is, at the time the apology was proposed, David Satcher, and you'll hear about him a little later, was the director of CDC. And so as we sat and talked about the syphilis study, and we agreed that the apology was necessary from the government. And somebody said, well, David Satcher is over at CDC. That's where the study was managed. Then he should apologize. Y'all know David Satcher?
Yes.
You know what he looked like? You know where he's from? He's from rural Alabama. So what sense would it make him to apologize? No sense. So we argued that it should come from the highest place in the government where the essence of ethics resides. That was in 1997. I'm not sure by now. but so we said no, it ought to come from the president. But at that time I was a federal employee, and some of us were also in the government, so we had to step back. I can't tell the president to apologize. That's where I get my check from. So we stepped back, and some stepped up, and then there was an apology. But a colleague of mine, an ethicist, said, well, what does an apology mean anyway? We've been apologized before. But that was the apology. I was there. And I want you to read what President Clinton said. And the part that stands out for me is the United States government did something that was wrong, deeply, profoundly, morally wrong. Remember what I said about morals? And remember what I said about wrong? Did I say anything about wrong? I'm a slow learner, so I have a bachelor's degree in biology, dental degree from Harvard, master's in public health, doctorate in public health, a teaching fellowship, a residency, and I never heard the word wrong. Not in class, not in residency. Wrong is new language. Moral in the context of my educational experience was new language. So he introduced some language to folk who didn't know what that meant. And I suggest that we still may not know what that means in this context. Something's wrong, profoundly, morally wrong. And those 4 men, 1, 2, 3, 4, 5, I knew most of them. And one of them said, well, we ain't mad at you. And it was wrong. And we forgive you, but just don't do it again. How can someone forgive? It's big. And that's the history of some of the folk that we see and serve. How do they forgive over and over again? I don't know, because I get mad and I stay mad. I'm mad when I'm at Tuskegee, because some of the stuff I know, I read, I interact with folks, and I get mad. They say, well, Reuben, don't be mad. I'm over that, you know. I'd be mad. That's what they say. We forgive you, but just don't do it again. And my anger is because we do it again and again and again and again and again. So that's the ethical dilemma, the ethical problematic. And that raises the question of what is ethics? Set of rules, principles, values, and ideals of a particular group of people. And what I'm suggesting that we are dealing with a particular group of people, what is ethical for the folk that we're serving? Not what is ethical for the health professionals education. The folk that we should ask them. Don't try to figure it out. They're clear. And their right may not be your right. Because if you come to Tuskegee and say the Tuskegee syphilis study, they're going to run you out of there. It may be right in Nashville and Washington, it ain't right in Tuskegee. Language. And we had to pull ethics out of philosophy. Because philosophers do what? Philosophize. And my context is that not only is it out of philosophy, but I would argue it's out of theology, which precedes philosophy from my context. So where does ethics flow? And so what the research and health professionals community said, well, we're going to call it something bio. And they came up with bioethics. Is a bio off there? In fact, well, just know it's supposed to be there. And it is the applied ethics focused on the doctor-patient relationship and how it changes in the healthcare system, how it affects it. Now, what the constructs, the principles of bioethics are: 1, autonomy. You have the right to say what's best for you, and I agree. The second one is benevolence, the intention to do good. I'm trying to do right. I intend to do good. You know, I didn't mean that. And then justice. But that evolved, and people from the time of the U.S. Public Health Service syphilis study in 1932 until the time it was exposed, there are a million, I don't have a slide because it's be too long, of all the bioethical violations around the world. So it's not that we didn't know better, it's what? We didn't do better. So bioethics just didn't fit, because it was about treating you right and giving you autonomy and doing and trying to do good for you. So because of my the journey in public health, I had to go back to the literature. You know, you have to go back there. And there's a notion, this term called public health ethics that was there in practice, but not in theory. So people were doing it because they were saying, it ain't working for you. but it's working for us. And then other places it's working for us, but it ain't working for you. So we have to wrestle with another framework. That's where that word came from. Public health ethics is maybe 20 years new. And that's what public health ethics is, and I'm gonna not insult you by reading it because I'll stutter. You read it. And see if you can sense the difference between bioethics and public health ethics. There's some principles that are embedded in public health ethics that bioethics doesn't address. It's not that they are wrong for not addressing, they just have to grow. Look at that definition. It has to embrace social justice. It really talks about more than just what you do as a clinician. It talks about the context of who you serve and why you serve them. And understanding that what you do is not the most important thing in their lives. Matter of fact, the most important things in their life maybe operate outside of their locus of control. Some of them talk about lifestyle. That's insulting. It's the circumstances that folks find themselves in.
Yes.
And it's the difference. Am I going to improve your lifestyle? Come on, y'all. That's the public health ethics dilemma. And it talks about in opposed to autonomy, which is what's good for you. It talks about community engagement. How do we engage with each other and define what's best for us? What's best for you and what's best for us is where the tension lies. But if you reflect on I am because we are, therefore we are because I am, there's no difference. I may have to compromise a little bit of what's best for me to get at what's best for you. That's bioethics, autonomy, public health ethics, community engagement. The second is intention. Benevolence, the intention to do good versus beneficence. What you gonna do? Don't tell me again about what you intend to do. What it say, the road to hell is paved with good intentions. You didn't told me what you're gonna do too many times. Beneficence, that's measurable, that's science. I can tell if you did it. And most importantly, I can tell if you didn't. And social justice, what is for the collective good? And let me finish by leaving you with what I think is the optimal, the ideal. And by the way, that this construct was developed by John Chazelle, MD, the Harvard Medical College, 1954. It is not by accident that he's a Mahari. And I followed him around for about 10 years. I didn't ask him any questions, followed him around. He could tell me stories about it. I was doing his rotation as a junior medical student. And he was got all the science about when he was doing OB/GYN or whatever that was. And he said he heard a holler in the women's bathroom, and he ran in there in time to catch a baby. And he said, I can't explain it. I ran in there in time to catch a baby. I don't know, but I do.
Yeah.
So Chazelle said that optimal health is the best possible emotional, intellectual, physical, spiritual, and socio-economic aliveness that one can attain. That's big. To reach your greatest state of aliveness, he said. That's optimal health. And he went on to construct 5 domains. And I won't take the time now, but that's conceptual, theoretical. And what he said, he made his transition here and on the 50th anniversary, graduation anniversary, at Manhattan, at the hotel. And somebody called me and said, Dr. Chazelle had made his transition 50 years at the hearing. And before he did, after I was following around, he said, look, why are you following me around? I said, I don't know. Because you have something to offer. And what I promised him, he said, I'm going to take your conceptual framework of Optimal and translate that into what we do. Not what we intend to do, what we do. That's a research agenda. And that's what we're doing at Tuskegee, translating optimal health. Let me close. I ask you if you do, David Satcher, you know you have to say yes. And some kind of way, he stepped here too. Everybody know you got to come to this place. He was president for several years. I was dean when he was president. And he was director of CDC, Surgeon General, and all the things from Anderson, Alabama. And his kinfolk probably went to study. And quite frankly, some of your kinfolk may did it too. We are finding out more and more as we translate the anger and hurt and shame into glory and honor. Folks say, well, that's my uncle, my granduncle, my great-great-grand-cousin. So we've transformed shame and blame into honor and glory. And the transformation is powerful. Matter of fact, I chaired the dissertation committee, a PhD student whose great-great-grand-uncle was in the study. And her dissertation is looking at the association between health disparities, food insecurity, and environmental justice. Now, if that ain't transformation, I don't know what is. That's her PhD dissertation. And she will be Dr. Carr come July. That's transformation. But see what Satcher said. We must know enough, care enough, do enough to make a change. There's a whole domain called care ethics. It is not embedded in science. And so I want to leave you not with the science, with another hero of mine, or Shiro to be more correct. And Dr. Angelo says, history, despite its retching pain, cannot be unlived, but if faced with courage, need not be lived again. May not be lived again. And of course, I want to say thank you and want you to kind of read about the Sankofa bird, because it embeds something in you, at least in me, that charges me with doing better. If not, as Dr. Giselle would say, if you can't do optimal, do better. And the Sankofa bird says literally, Sankofa literally means go back and get what was taken. After the term made its way to the United States, African American scholars coined the term to mean remembering our past, protect our future within the African American culture. And I'm suggesting that this place, this program, this effort where we're enjoying is really not new. It's going back and capturing what we know we ought to do. And I want to thank Dr. Matthew Rex, and Paul Rex, and Dr. Brown for going back and catching what we know we ought to be doing. You couldn't do it anyplace else. You're doing it at the right place and at the right time. Thank you so very much.